Our final subject for this issue of ACCEL features a talk I had with Dr. James Somerville, Emeritus Professor of Cardiology at the Imperial College in London. We cover Lessons from a Legend, Pediatric Cardiology. Perhaps we could start out by just talking about the issues of adults with congenital heart disease, because I think you mentioned earlier when we were talking that the population of patients is growing rather than getting smaller.
Well, first of all, I'd like to say I'm very happy to be here, as ever and as always. I think that it's nice of you to say I started it, but I think others have made great contributions, particularly the Canadians, who started a long time ago. John Keith had the wisdom. Joe Perloff and I were sort of parallel figures doing the similar things, strangely from very similar origins as it happened. Now, today we have advanced. There are services for these patients in certain countries, but not a lot around the world. And I think that the population is growing, particularly where there's been successful congenital heart surgery for infants and children. And of course, in those countries, including our own, they probably outnumber the actual pediatric cardiology cases. And if they don't now, they will soon. So there is a problem in these well-developed countries where money has been lavished on care in infancy and childhood. Expensive it is. So there are survivors. And there are problems, and they do have problems, and the dream of total correction applies to almost very little, the surgeon's dream, and they still have problems later, even some simple conditions. But even those with complex, who have a much better outlook in life, are surviving but do need a lot of care, which requires specialist knowledge and understanding that Mr. Average, well-trained cardiologist doesn't have. General physicians even less. And so there is need to be this subspecialty, just as much as there has to be a subspecialty in electrophysiology, prevention, whatever.
You've been visiting us in the United States here for many years and have watched how care is provided here. What are your perceptions of how we're doing care for adult congenital heart disease here in the United States?
Considering what an advanced country this is, and how much one has learnt from the many innovations, I am shocked that it is not better. And I'm really shocked that you've not got it together, except in relatively few centres. For your huge population, it is not done in many centres. Many may claim they have a centre or a clinic, but the actual expertise and the care for this population, I don't consider is good in this great country.
I suppose part of that is because our healthcare system isn't as well as organized as healthcare systems in Europe, particularly UK and others in Canada. How did you move this forward in the UK, for example?
Well, before I answer your question, please forgive me. I'd like to just answer why it isn't great here, as far as I can see. And I think it's a basis of money. I think people won't transfer their patients, and they remain in private practice where most don't have the expertise. They remain in pediatric care, which is not appropriate for adult care. They remain somewhere they don't get recognized at all, depending on the level of care that a patient or family receives. Or they're just sent to the winds and they're not on insurance policies. It's somewhat better with Obamacare, but I think it's related mainly to money, if one came down to it, as well as lack of expertise. So that's from your country, and I don't mean to be critical, but I am concerned for your patient group, which is large and ill cared for, in my view.
Yeah, in the United States, we have some interesting cultural differences, particularly parts of the South, where there's a lot of poverty in small cities and small towns and not many physicians. Most of the physicians are primary care docs, don't really get aware. And that's a population sometimes which harbors adult congenital heart disease and nobody detects it. And I think that's part of the issue. These folks go very far into their disease before it's overt enough to be detected.
It's a multifaceted problem, but basically it relates to money. Now, from our point of view, how did we get lucky? Well, we established services with considerable difficulty, and I would say it took about 25 years. But we have a huge advantage in our National Health Service being free at the point of entry. How long that will be, that's another debate and discussion. So that was one thing. It was opposed. It was obstructed, I find, with most good ideas I have. I don't know how other people get on. They get obstructed, certainly in my country, perhaps in many others. And then there are other reasons for it, but we got organized. I think having established the principle, it was much better when I left the scene and played elsewhere. And they got it together, and the Department of Health was forced into it, actually by my patient association. They had a very good leader who understood politics. And he just went and he spelled out what had to be done, and now it's well organized. And the centers were deliberately limited because of the amount of experts they need. So we have so many centers, I think it's 6 per population. I mean, you don't have many more than we do, really well staffed. I could count 9 when I looked, one would pass, and they're subsidiaries. But we have good centers with a sort of hub and spoke. The ministry loved that word, the hub and spoke. There's a center, and then you lead out to other clinics, and they like that. And it's been organized. So most patients, with the Patient Association assisting and shouting at the Ministry of Health all the time and watching, it's got organized.
So the hub and spoke idea, I think, is a very, very good idea. In the United States, of course, we've now completed a board exam for congenital heart disease.
Which is excellent.
Which now defines the expertise we need for the hubs. And I think that by itself will raise awareness. If there's a hub with people that are board certified, that are considered experts, then they can start to recruit their spokes.
That will be very good. The problem is the length of your spokes are very long here, and the geographical problem is very long, so you need many more centers because people can't afford to fly unless they have a special help and need. So the finances have got to be dealt with.
Yeah, which would also, I guess, beg for some of the hubs to be put in areas where they need them, rather than expect the patients to do the travel.
But we have trained enough, and I like to think I made a contribution to that, but we tried to tell this great country where I love visiting and learning, tried to tell the deans that when people wanted to do it, we'd like to help because it was wonderful to have your fellows. But their training in the UK, specialists, was not recognized as part of their training. I had many arguments with several distinguished deans and got sent off. So I said, why should I worry about your country? I've got enough of mine.
Yeah, well, I think now with the board certification process, we can send trainees to England for training as part of their training, and that gets counted as legitimate training.
Well, I think is good because practice. Everybody's problems, they're very similar, the problems across the board, but they've all got somewhat different, and they're changing. The grown-up congenital hearts we see now are not what I saw 25 years ago when I was shouting. They're different, and techniques of repair and the ability to do more perfect work by the surgeons and all the imaging and so forth has made a huge difference to the specialty.
So a couple of key advice for cardiologists at this point, or people that want to go into training, what would you offer people?
Well, I'd like to just come away for why I'm here. I have an awful brief advice from the legend, thanks to the American College of Cardiology, and one of my trainees being much honored, which is great. And I like to be here, but advice for women cardiologists, I can't go around advising men, there are too many of them. And this has been very difficult. I think it's a complex story for women, and I don't want to appear patronizing, but I think so-called success, however it's perceived, comes from many of the qualities you're actually God-given, born with, if you like, and those opportunities that you encounter and acquire. And that's it's like health. What makes you in the end is what you've acquired and what you got. But you've got to grab opportunities. You've got to focus your goal. And there are a few principles that I don't think there's time to enumerate that you have to stick to. But I think determination and delegation to other people of the trivial tasks you don't want to do as a woman, such as ironing wretched shirts, all have to be thought out and brought in to play. And now that there are more women with ambitions, they still have to be women, and I think they should be proud to be a woman and not try to look like a man or be like a man. We were not liberated to do that.
And this may be an interesting area for women to follow up on as well. That is the area of adult congenital heart disease, with you as one of the real models for how to move this forward.
I think nobody should follow me as a model because I've had lots of chances and lots of fun and am rather naughty, as is known for it. But I think that it is a specialty that women do very well in because it's rather like sort of being a mother or an aunt and dealing with all the problems that families and particularly young people produce.
Jane, thanks again for being here. It's always a wonderful interview when we have a chance to chat. And I look forward to many more of these in the future. So thanks again for coming.
Happy to be here.
And that concludes this edition of ACCEL for November 2016. For details about studies discussed on ACCEL, refer to the written summary that's included as a PDF file on this disc. This issue of ACCEL qualifies for up to 4 Category 1 CME credits. To obtain CME credit, go to www.audiodigest.org/online testing. This is Alfred Beauvais for the American College of Cardiology. Thanks for listening.